And then we look at the adenocarcinoma. That is basically when you talk of adenocarcinoma, it originates from epithelium, but epithelium in this case of the glands. So remember in the prostate, we have a prostatic glands, and in those glands, it has an epithelium. And so most of the cancer of the prostate originate from the glands, the epithelium of those glands. That's why it's called adenocarcinoma. So when you talk of adenocarcinoma, you're talking of a carcinoma that originates from glandular epithelium. So malignant cells invading the prostate as glands, cribriform structures or sheets. So it can appear like glands, can form a lot of glands. It can form cribriform is sieve-like. All of us know about the sieve, S-I-E-V-E. Sieve is the one, for example, you use to sieve your tea and so on. So it appears like that, sieve-like. So it has perforations and so on, or it can be in sheets. Usually arises in the peripheral zone, as we've already said, of the prostate gland, as opposed to benign prostate hyperplasia, which characteristically develop in the periurethral and transitional zones of the gland. Transitional zone is the gland, the side that is around the bladder, and transitional tend to grow throughout life. So almost all prostatic primary malignant tumors are adenocarcinomas, as we've already said. And there's sometimes we use what we call PSA, prostate-specific antigen for screening. It's a blood test. Yeah, and there's a normal range. Most of the time, most lab will give you 0 to 4 as the normal. So if you find a PSA maybe of 10, that is elevated. In metastatic, sometimes you find the PSA is more than 100. So if you see a PSA that is more than 100, most likely they have prostate cancer that is already even metastatic. But elevated PSA doesn't necessarily equal to cancer. What you need to do once you have, so most of the time PSA is actually more, we call it tumor markers. Yeah, and there are so many other tumor markers, even in the other part of the tissues. So PSA is not very specific. So once you have a very elevated PSA, usually the next step is you go do a prostate biopsy. You get some biopsy from the prostate and take it for histopathology for them to see whether there is abnormal or cancerous cells. Yeah, so elevated PSA doesn't mean necessarily cancer. That is the point I want to bring, so that you wouldn't have people being told. And even PSA, there is still a lot of argument whether we should use it as for really screening. You are likely to find a lot of men. Sometimes we say some men actually die with prostate cancer, but doesn't die of it. So you may find a man who died at 90 of another cause. If you do postmortem and look at their prostate, you realize they had a cancer, but it had not spread. So sometimes if you are to do PSA for everyone, then you will cause a lot of scare sometimes. So that argument is still there amongst the urologists, whether to do PSA for every man 50 years and above, or which age to start, and should we do it at all? Would we create a lot of fear out of men who will even have died of other things without necessarily dying of cancer of the prostate? So looking at this so this is basically, if you are to look at histopathologically, you can see microacinine, loss on convolution, and so on. Perineural invasion means it is invading the nerves that are within the prostate, because the prostate still has to have the nerve supply.